Hello, everybody, and thanks for joining us for another episode of Coding with Christine Hall. I want to say good morning, good afternoon, good evening, as the good Dr. Tedros always says. And I'd love to introduce you to my friend, Dr. Ken Rosenstock. Dr. Rosenstock, thank you so much for joining us today.
Hi, Christine. I want to thank you for inviting me today, and I'm looking forward to our discussion on a lot of interesting topics that I know we're going to advise a lot of coders about these issues of the musculoskeletal system, and I think it'll be beneficial for all of us.
I'm so looking forward to it. To start us off, we have National Strawberries and Cream Day. My friend Terry Fletcher always likes to know what the national day is, so I try not to disappoint. National Strawberry and Creams Day. So that might be what dessert is. I have to tell you, okay, we're friends, so I might have a bit of a whipped cream problem. I think admitting it is the first step, right? It's probably one of my top fives is a big hunkin' spoon of whipped cream. But today is also National American Red Cross Founders Day. So that's pretty awesome. Congratulations to the American Red Cross and everything that you do for us and the entire world, actually. I think that's awesome. But like you said, we're here to talk a little bit about the musculoskeletal system and from that billing perspective mostly, because we're going to talk about CPT codes and resources for CPT codes and reporting CPT codes. And I know you do a lot of auditing of musculoskeletal. So I was really interested in your perspective of maybe what are some of the biggest issues that you see when you are auditing musculoskeletal.
Yeah, I think one of the biggest issues, Christine, is the issue of unbundling of codes. And we can talk about that from shoulder arthroscopy to knee arthroscopy, spinal injections, even, foot issues as well. But it's a big thing with writing in the 59 modifier when it may not be supported. And it's important to review the documentation as an auditor to verify that what's in that record and what's in that op report supports the 59. Now, we're assuming that these are soft edits. There are still codes that, get that 59 by providers, but they're certainly not going to get paid anyway because they're considered hard edits. So it's very important for the coder and the auditor to understand these edits, why they are in place and why they don't allow, because the procedure that is the column 1 includes the column 2 code. It's part of it. The pricing is inclusive of that, unless you're doing it on a separate structure, making a separate incision. The construct is not a standalone. So, these are all things that auditors really are focused in and drill down upon when they review the records.
Well, I think that our billers and coders, they need to remember when you're talking about bundle, you're talking about the things that are included. So one of the things that always comes to mind with musculoskeletal system is the inclusion of local anesthesia. Like I do a lot of orthopedics. I have a connective tissue disorder. So that my orthopedic is almost, I see them more than I do my primary care. And one thing I can tell you is never once have they told me, Christine, this is going to hurt. Now you have a choice. You can either have this piece of leather to bite down on, or we can give you lidocaine for an extra charge. Okay, that never happened. They've never tried to charge me for the lidocaine. And that's because it's bundled in. It's included in that payment already. So to what you're saying, I know that there are still some groups out there that try to bill extra for the lidocaine or try to bill extra for the evaluation and management or the supplies that are already included, casting or splinting that might be included in a fracture. You could tell somebody, yeah, that's fractured and I can realign it. But if you want it to stay, you're going to have to pay me more money to put a cast on. Like,
right.
I've never heard that.
Right. So we really have to understand the HCPCS codes that are associated with these injections. And it doesn't matter whether it's in the foot in a small joint, a middle intermediate joint in the ankle, or a large joint, of the knee or the shoulder. If you're going to start billing for these locals, you're going to get denied for it because they are not separately payable. They are inclusive of the injection code itself. Now, if you want to talk about the corticosteroid that's involved, that
Mm.
is separately reimbursable. I can attest to that in my past life
Mhm.
because we would get paid separately for that. And I just wanted to bring up the issue of the new coding of the steroid, that it's changed as of April 1st. I'm sure you're aware of that.
Yeah.
J1100 is the new code for one specific steroid, and J1040 and J1030 are gone. So, it's very important milligram to milligram that as the doctor, you're documenting this correctly by the amount of milligrams, and the doctor really needs to state what it is, not just that he gave an injection in the joint. It's important in the documentation to say and indicate how many milligrams and what concentration it is.
Right. I couldn't agree more with that because I think a lot of coders don't realize, especially when we teach coding, that HCPCS codes are updated quarterly. It's not a one and done. It's not a once a year. And um, although it gets published once a year, it is still updated quarterly. So we may have those changes just like we had in April that coders need to be aware of. They need to be on the pulse of.
Yeah, that's correct.
Yeah. So a couple of other areas you mentioned earlier, NCCI and column 1, and I just wanted to elaborate on that a little bit. I think musculoskeletal is definitely one of those areas where it's super important to be checking your NCCI edits. They also update quarterly. So maybe you want to keep a tickle in your calendar, a little tickler, that at the beginning of every quarter, you go through and you review all of those CPT codes or HCPCS codes that you report on a regular basis, just to make sure that the edit hasn't changed in some way, either due to a HCPCS update or just a general guidance that NCCI can provide us.
Right. So it's very important that the coders are either going on the CMS website, because they're the ones who update these edits. And it's very important that the coder is looking at the dates in those columns to confirm that the edit is still active. Now, I use Encoder. My business gets Encoder. So we see the edits as they most currently exist. It's just for the current year, but it may not be retrospective. So that's why it's important, even if you have a software program like Encoder that you work with, you go back and you cross-check historically to what it is. And it'll say in the spreadsheet from CMS when the start date is and when the end date is of that edit.
Yeah, absolutely. And I think you made a good point there. The changes usually come from CMS, and they'll come in the form of a transmittal. Now, one of the things with transmittals, don't think that Medicare, just because you're a participating provider, that Medicare is automatically going to send you emails about the changes that are happening. The responsibility lies on the individual provider and the provider practice. So it really relies on that coder or that biller to make sure that they're going in to look for those transmittals. And that transmittal is going to explain why an edit has been put in place. But more so to your point, when is CMS or when are the payers going to start enforcing that new edit? That's always going to be part of those transmittals or those changes that are happening. That's the awareness that comes through to us. And so, like you said, if you have an encoder, your encoder is usually pretty good about letting you know when those things have changed. But if you don't have access to an encoder, it's still up to us to make sure that we're double, triple checking that information.
Absolutely. It's very important to be on top of these things. And as coders, this is what we do. We're always trying to learn and gain more knowledge, and it's integral in order to make sure that the reimbursements are correct and that we're not missing something.
Dr. Rosenstock, I think your video is stuck.
It is.
Okay, I don't know if you
Tell
want
me
to.
what I can do.
I think, oh, look at us troubleshooting here. This is awesome. It maybe stop camera and go back to camera. Try that
Let me
and see if
try.
it works. That's great. Oh, it might still be stuck. At least it wasn't stuck on a bad picture of you. It was all right.
I'd prefer to see myself moving, though.
Well, if it's uncomfortable, you can turn your camera off if you want to. It's up to you totally. It's not a terrible picture to be stuck on, but it's up to you.
That's okay. I think I'm going to turn it off.
Okay. Our listeners really just want to gather your knowledge, your expertise, and we appreciate that. So
thank you.
Sure. So the other thing I want to remind people about, another area that we get new information is in the annual publication of CPT. So on January 1st, those CPT changes go into play. And if you get your book and you look through the musculoskeletal surgical section, what you're going to find in there's a lot of green ink. Now, most of us that have been in the industry a long time, we know that the green ink means that that's new information. It wasn't in the book prior to. So at least once a year by January 1st, you need to be looking in your CPT books, or again, if you have an encoder, that you're going through your sets of codes through your encoder to see if any of that guidance has changed. One of the areas that comes to mind, Dr. Rosenstock, are the facet joints. I feel like facet joint instruction has changed almost every year for like the last 5 years.
Yeah, this is a thing that's ongoing, and it's very important to read the guidelines because they change each year. There are small, subtle nuances that the AMA will integrate in, and that is a very important thing to understand going forward because look, Christine, it's kind of like the E&M guidelines. We didn't change the E&M to medical decision-making only until 2023. So, again, as an auditor, we're looking back and saying, okay, what is the data service here? Let's look back and see when did this change take place where only MDM is the dominant point. Because if it's not, and you go in and you say, well, there's moderate medical decision making, but it was done in the emergency room, you don't know what the other two components are if the date of service was in 2021, right?
Right. Exactly. You have to know the rules for the date of service that you're looking at. Now, for those coders that are doing real-time coding, that may not be an issue for you, but what I like to say is, how do you know you're doing a good job? Don't rely on the fact that your boss hasn't come to you and written you up yet. Do your own due diligence. Be your own educator. Make sure that you're doing little audits for yourself, right? Maybe at the end of the week, you pull a couple of charts and you go through them just to make sure you have the most up-to-date information, you're following the most up-to-date guidelines by the individual payer so that you know. But the dates really become very important when you do get into that auditing role, when you are looking at retrospective dates and looking at the specific instruction for it. And sometimes it's through those audits that we find that we've been using some old information maybe, and that we need to change the way that we're documenting or reporting certain services.
Right, exactly. And as auditors, I mean, you know what the auditing process is. Part of auditing is not just looking at something and comparing the bill to the medical record. you're also creating a report of sorts, and you're making the provider aware of why what they coded does not line up. And you're saying, okay, this is what you should have coded. So this is an integral component to what an auditor does. It isn't just, here's a bill, here's a medical record, and let's see if they line up. The third component of being an auditor is advising the provider of why the code that they build is incorrect, and the supportive information that comes from AMA or comes from CMS, like an edit, that supports what you're espousing when you say, this is not supported, this is why.
That's exactly right. And I usually take it one step further. I usually provide the resource link to where that authoritative information came from. So remember that, guys, when you are going to give information like something has changed, doc, the documentation needs to support this, or that it now includes this. And so we have to make sure that we're not separately billing that, or whatever that case may be, that you're not just giving them that oral information, but give them the power to research that themselves. And that helps support you in the long run. It will build that level of trust with that provider to say, every time that Dr. Rosenstock comes to me and says that these two procedures cannot be reported together, he always gives me this authoritative resource. So, moving forward, everything that Dr. Rosenstock says is fact-based. That confidence level has been put in place.
Yeah, absolutely. And, part of the reports that I create, I make sure that I'm consistent among all of them, that there's no variance. So you're not taking any, partisan view, if you will, toward one provider or another provider, that you're applying the same principles across all the providers that you're reviewing. So, this goes beyond the musculoskeletal system, Christine. I mean, it covers other specialties too, that. So, we want to make sure as auditors that when we review these things, that we're applying duplicative aspects to all of the codes that we review, and that it's so elegant across the board. For multiple times that we review their bills.
Yeah, absolutely. So I do want to switch gears just a little bit. And I want to remind people that in musculoskeletal, when we start talking about bundled items, not only do we look at it from just the facts that are given to us in CPT, but I also want to remind a lot of people that Medicare also has a global package. I'm not talking about the global period, but a global package. And the difference between the package and the period is that the package are all the items that are included in that CPT code. They're not limited to the period, like the global period of 10 days or 90 days. The package is the package. The payment includes everything in the package. So it's important to know between each one of the different types of payers, what are their perception of package? In the absence of a payer-specific designation of that package, we revert to CPT, which tells us the E&M is included, the administration of lidocaine is included, casting is included, traction is included, splinting is included, all of that information from CPT. But CMS tells us that there's even the removal of subcutaneous sutures or staples is part of the package, not the period. So those are the types of things that I want to remind our listeners, that when you're talking about unbundling, what are some of the other things that you see that are often unbundled in the musculoskeletal section?
Yeah, this is a very interesting thing, because a lot of times you'll see these surgical wounds dehiss, and the doctor will then bill in for, say, an ulcer debridement because the wound dehisced. But technically, right, that's part of the global surgical package unless the patient returns to the operating room. and you're
Hmm.
going through a major debridement. You're going back in, you're taking bone out, you're taking, revising the skin incision. You may be applying a skin substitute to
Yeah.
facilitate wound closure. All of these things you have to differentiate. And I will tell you, Christine, I see a lot of doctors who bill for 99024, right? And
Yes.
they bill a price for it. And it's another, thorn in my side that,
Yep.
we deny, because 99024 signifies a global package item of a wound dressing change, right?
Right.
Perhaps maybe a lavage of a wound, not just, applying steri strips or
Right.
removal of
Right.
skin sutures. This is all part of that we incorporate into the global surgical package, as you say.
Absolutely. And we do. I do see providers all the time. And when I go back to that 99024, I remind them that that code has a status indicator of B, meaning that it is bundled into something else. It's bundled into that procedure that you build. So there is no additional reimbursement that is going to be given for a code that has a status B. So providers, please listen to your coders and billers. These are things that we learn along the way, and this can be very helpful to you. It's not beneficial to an accounts receivables to have expected money showing that there's no entitlement to. That's a status B code. You're never going to get paid for it. It creates problems way beyond just from a billing perspective, but later as we get into accounts receivables and working those, it creates another problem that we may have to put costs out to address when there was absolutely no need to. There was never a reimbursement that could be pending.
Right. And it's important, you mentioned about how individual payers group this stuff. So I will say from my experiences that a lot of payers parallel themselves off of CMS.
Mm-hmm.
So while you should be checking your individual payers, most payers reflect how CMS processes their claims. And, that applies also to assistant surgeons, right, Christine? So there's going to be a
Absolutely.
certain percentage that an assistant surgeon is going to receive, and a lot of payers parallel that right off what CMS does.
Well, because a lot of contracts, people don't realize this is some. I'm just going to go off for a second on a little tangent. I think that one of the most um, dissatisfying or credits that you can give to your staff is not letting them see your contracts. The billing department really needs to know what is in that contract between the provider and the payer. Oftentimes, our payment is based on a Medicare fee schedule, a Medicare physician fee schedule. And we need to know what year that fee schedule was. We need to know if that payer has negotiated a more than 100%. Maybe the payer says, listen, I'm going to pay you 150% of Medicare prices from 2006. Well, that's really going to make an impact, because even doubling or 150% of that Medicare of 2006, you're losing probably $40 on every single patient you're seeing, because that reimbursement back in 2006 was not that great, not that impressive. Things have changed since then. So that's just one of the reasons why I think that the contracts are important to share with the staff, so that they can be aware of who is that payer mirroring for payment purposes, for policy purposes. And like you said, a lot of payers will mirror what Medicare advises in lieu of having their own policy in place.
Yeah, that's correct. And a lot of times these contracts don't actually include what the percentage of Medicare is. Sometimes, you can be a participant in a Blue Cross policy and they won't share how they internally process claims, but it's possible that they may apply a percentage of Medicare pricing when they develop their own fee schedules. A lot of times we really don't know. So a lot of times carriers, especially in the world of personal injury will, develop pricing of services that aren't on fee schedules, right? Based on a percentage of Medicare, whether it's 200% or 250%, even for
Right.
facilities, it could be 300% of Medicare ops. There's a lot of different nuances that go on here. So it's a complex world, but it all cycles around, starting with how CMS processes these claims.
Absolutely. And we have a link here to the Medicare Global Surgical MLN, Medical Learning Network, is their fact sheet. And I love to reference this because the fact sheets are always written in plain words that I understand. I don't need to be a clinical person or a PhD to understand what they're meaning in these types of fact sheets. One of the things in this particular fact sheet that's interesting is that the global surgical package, not period, under Medicare also includes certain complications are covered under the package, where CPT never talks about complications. That would be something that we could possibly, if we didn't have that Medicare guideline, we could have used a modifier 24 to indicate that it is not directly related to the success of the surgery, but it's a complication. Medicare says complications are part of that surgical package.
Right. That's correct. It's important that we understand that, especially with the 24 modifier, Christine, because that has to be for a distinct diag during that post-op period. So, if you just had a cervical fusion and you're treating that patient for a lumbar issue, then that's a different story. But if you're going to append that 24 and then not mention a word about the lumbar issue, and it isn't just that you're mentioning about the lumbar issue, you're treating the lumbar issue on top of that. So 24 is a very dicey thing that a lot of people try to bypass that global package with, and it's very important that the coder understands what these modifiers mean and when they can be used and when they can't.
Absolutely. And the last thing I want to kind of throw out there before we finish is that I want to remind all of our coders, billers, all of our administrative staff out there that learning this information, well, first you're here, so that's great, right? But learning this is information you keep with you. This is information that empowers you, that makes you the best coder, the best biller, the best auditor out there. That's what sets you apart. You're not waiting for your employer to send you to a conference or provide you with this education. You're taking the power and you're educating yourself. Again, reading this information, watching these podcasts, reaching out to other people in the industry to make sure that you've got the right information or that they can send you to an authoritative source that you can share with your providers. But how important educating yourself is. Don't rely on your boss, your administrator, your supervisor, your manager to provide those opportunities. Sometimes you've got to take the bull by the horns. You've got to be the one who's looking quarterly to see if things have changed. Has the policy changed? What's going on with the package information? And Betty made a very good point earlier. You have to make sure that you have signed up with your MAC, or even go further, your MAC and CMS, or your MAC, CMS, and the payers that you participate with, so that you start to receive notices from them. They're not just going to arbitrarily spam you with information. You have to actually go out and ask for those emails to come into you. So please make sure that you're doing that.
Yeah, I think it's very important that we emphasize the necessity of not just getting your base CEUs for the AAPC. Look, Many of us have multiple. We have multiple certifications, so we're definitely needing to get more than what it is just for a CPC, but we shouldn't stop there. We as coders really need to exceed what the AAPC minimum is. And, I recommend to my colleagues that, they listen to Terry Fletcher's podcast. It's a very short, quick, once a week podcast. I try to do the webinars on the AAPC website. I attend my local chapter meetings as often as I can. We have to emphasize the importance of learning. It does not stop. We have to make sure that we're understanding the changes annually when that CPT code book gets released in October, so that we are up to date on all of the changes that are going to go into effect in January. It's very important, Christine. I can't emphasize that enough.
Absolutely.
As coders are perfectionists, and if we want to be held to the highest standards possible, we have to, do our due diligence.
Absolutely. I cannot agree. I can't believe we've already reached our time together. Wow. It always goes so very fast when I'm hanging out with my friends and we're talking about things that we're so passionate about. I can't thank you enough, Dr. Rosenstock, for coming on the show today, sharing your knowledge, your expertise with us. I want to put your information on here. Let's see if we can get that up there. If anyone would like to reach out and talk to Dr. Rosenstock, Ken, most of us know you as Ken in the industry.
Thank you.
And reach out to Ken. And if he's on LinkedIn, very active. And I'm sure that if you have any questions, he'd be happy to help you out.
I want to thank you very much for inviting me today, Christine. I apologize for not seeing my ugly mug on the camera, but I did my best, and I'm going to do my due diligence in future things so that this doesn't happen again. I don't know if it's something outside of my control, but I really want to thank you. I enjoyed chatting with you. I hope we get to do this again at some point in the future.
We absolutely will. I thank you so much. Thank you everyone for joining us today. Make sure that you have your strawberries and whipped cream later, and appreciate the American Heart Association. It's a wonderful organization. I'm sure they're going to have a lot of things going on social media this week. So keep an eye out for that. Thanks, everyone.
Thanks for watching.